This is the Neurosurgery Podcast. Welcome back to the Neurosurgery Podcast. We are very excited today to be kicking off another series that the good people at Elekta were kind enough to sponsor. Last year, we had a great series from our friends at Elekta spotlighting the use of Gamma Knife technology in the States and around the world in Europe. And we were really privileged to kind of dive deeply into all the different applications of this technology, from tumors even to functional neurosurgery. And that was really informative. We got to hear from a lot of exciting surgeons using that technology. And so they were so happy working with us and us with them that they asked us to do another series spotlighting surgeons around the world in a few different categories than just the fun that people have with Gamma Knife. And so coming to you from Elekta through our podcast, we're going to be spotlighting some leaders and some women in neurosurgery from around the world, and then also neurosurgeons in emerging markets in different nations around the world. And so we are just delighted that for the first conversation in this series, we are joined by Dr. Rupa Juthani. Dr. Juthani practices in New York and New Jersey. The group is Neurosurgeons of New Jersey, and we are just delighted to have you on the show today. Dr. Juthani, take a moment, say hello to our audience.
Thank you so much. It's such an honor to be here. I'm excited and very happy to be the first one in this series. And, representing women in neurosurgery and underrepresented groups is one of my passions, along with Gamma Knife and minimally invasive treatment. So I'm so excited to be talking about all of this with you.
Phenomenal. So before we started recording, we were just joking about your academic pedigree. I did a little homework, and I was looking up where you trained and went to school, and I said, "Wow, if someone was planning to go into neurosurgery, you could not have planned this pathway better." If you look at the institutions from Duke to UVA to Cleveland Clinic, Sloan Kettering, and now in practice now. So tell our audience, as we were discussing, when did you get the bug? When did you first think of being a neurosurgeon?
Thanks. Yeah. It was not happenstance. I think that I had wanted to be a doctor from a very young age. My father was a psychiatrist. I used to shadow him in the hospital from when I was probably about 5 years old. And I just always had a passion for science and biology. And when I went to high school, I went to a science and tech high school that was very supportive of careers in biology and in science. And I fell in love with neuroscience. I started my own neuroscience class in high school, and then when I got to college, I knew I wanted to do neurosurgery. Duke has incredible program, and I was fortunate to get exposure early on. And at the University of Virginia for medical school, one of the premier neurosurgery programs in the country, I used to go to conferences every Saturday morning at 7 a.m. as a medical student, believe it or not. And every minute I spent with that department just made me more and more excited to be a neurosurgeon. So
How did you do on the brain slices?
I was very precocious. They were very surprised that a first year medical student, uh, you know, had so much interest in it. But it was just because it was what I had wanted to do all along, and it was such a passion of mine. I majored in neuroscience in college, so everything I've done has just made me fall in love with it more and more. So I'm very fortunate, very grateful to have a career like this. Something that you love. You wake up every day and are excited to do.
Yeah, now I'm gonna, warning, this is a joke, but we recently we had a medical student on rotation with us here. I'm training at Rush, and it was her first day in the OR on our service. It was just a standard third year medical student rotation. And I said, "Oh, what do you want to go into? Are you going to be a surgeon?" She said, "No, actually, I'm interested in psychiatry." And we were doing a brain tumor, and I said, "Oh, great. Well, let me show you how we really fix brains." Did,
I love it. Yeah,
do you
exactly.
give your dad a hard time at all?
All the
When
time, all the
yeah,
time. Yeah. I always joke with him. He's like the hardest working psychiatrist in the country. I was like, you might as well be a neurosurgeon for the hours you work. So, I thought
right.
I'd just do that. So,
Well,
but
we'll
it all
talk
goes
a bit.
hand in hand. So,
Yeah, exactly. Talk a bit about your practice now. What kind of things are you doing in your current practice?
yeah. So, as I trained at the Cleveland Clinic, and I did a lot of, I started focusing towards the end of my residency there on tumors. I became very interested in endoscopic skull base surgery, which we were developing really towards the end of my residency there. And then I did fellowship at Memorial Sloan Kettering. So I, spent 2 years doing research in glioblastoma and in metastases. And then I spent a clinical year doing a fellowship there. So my practice has always been geared towards tumors. And then I was attending at Cornell, and I became even more within that subspecialized and interested in more minimally invasive approaches to tumors, and building more of an endoscopic skull-based practice, and a lot of interest in non-invasive treatments like gamma knife radiosurgery for neurosurgical pathologies and for tumors in particular. So now, I'm very fortunate to have kind of my dream practice, which is that I'm really a brain tumor surgeon. I do all brain tumors and all skull-based surgery. So I do, a range of skull-based surgeries from tumors to functional indications like trigeminal neuralgia. And that pairs really nicely with a lot of the other less invasive work I do. So endoscopic, pituitary, and anterior skull-based surgery. And then
Hmm.
with the gamma knife radiosurgery, where, we're treating a lot of similar pathologies, acoustic neuromas, trigeminal neuralgia, and then of course, our malignant tumors. So for me, what I love about this pairing of practices is that when I'm talking to patients, I can tell them that I do all the things that we
Mm.
do to treat these tumors, right? So I can say, there's an acoustic, and I love doing surgery for acoustic, but the right thing for you is to have gamma knife, and similarly for trigeminal neuralgia, microvascular decompression is beautiful surgery, but for the right patient, for patients that are better candidates for gamma knife or alternative treatments, I'm going to tell them that. And that's, one thing that helps me feel, very authentic with my patients, and that, I feel like I can counsel them from a very early stage in their diagnosis about, what would be best in their treatment plan.
Mm.
So, Rupa, I mean, to echo what JP's saying, you're coming from multiple institutions with, I should say, like academic, tertiary care level gamma knife. When you think about UVA, you think about Dr. Steiner, you think about Jason Sheehan, right?
Yes, my mentor when I was there. Yes, Jason
Jason,
Sheehan.
yeah. And then you think about like Cleveland Clinic, you think about MSK. These are big centers that are known. People travel from around the world to come to visit, right?
Yes.
Tell us a little bit about something that I'm not as familiar with, which is you are essentially in a private practice setting, but you also have an expertise in gamma knife. Like, how does that work? How do you build a practice? Was that
Yeah.
a difficult thing to start? Because the gamma knife's a big deal, right?
Big deal, yeah. So I was really fortunate. So the first thing I'll say is, I'm incredibly fortunate. I'm in a very unique practice. So, we are a neurosurgical practice that's highly subspecialized. We have 22 neurosurgeons. So it's very large. We're very, very, we're the number one practice in New Jersey. And it was the practice actually was originally had grown out of Columbia Neurosurgery. So it was the Columbia Neurosurgery faculty practice, and they ultimately divided. And so everybody in that practice before I even joined had a very academic mindset. They're very subspecialized, and they had already built this gamma knife program. So Tony D'Ambrosio, the head of our group, he was one of the pioneers out here in New Jersey, and our mission has always been and remains to bring the same high level, highly sophisticated care that you get in the city at these major academic programs right here in New Jersey, in a setting that in many ways actually serves our patients better, because the patients are getting kind of more of like a concierge service, a lot more personalized attention, and just like a beautiful hospital with state of the art facilities. Um, and so we're able to bring all of our expertise as neurosurgeons who trained and worked in the city here. And what we always say is we can offer patients the exact same care that they would get there, but right in their backyard. And that's always been our mission. And maintaining that level of quality has been one of the premier sort of features of our program. And it's really the reason that I'm here. Like, as as you can see from my path, like I've always been very academically inclined. And one of the reasons I was recruited out here was, for my expertise in the endoscopic skull-based surgery and in gamma knife, and also for my work with clinical trials. So I run a lot of clinical trials here as well. So,
Oh, wow.
it's this sort of idea that you can only get good care across the river. Like, that's been really what we've really worked very hard to show our patients is not true, and the community here knows that. So we're very fortunate for this community, this referring provider base, that loves the care that we give and the outcomes that we have. So yeah, I've been lucky. I can't take credit for the Gamma Knife program. It was there before I got here, but I've been fortunate to be able to help, to expand it, and we're very, very eager for what's to come.
Yeah, I want to put a pin in the clinical trials and hear more about that, and kind of the same question about how you get that organized and funded and run and approach patients about it in a private setting, a community hospital. But I am curious, with you talking about having these conversations with your patients, same level of care right in your backyard. That's a great line. Um, we talk a lot on this show, and just talking with people around the country about what it's like to practice neurosurgery in a big city environment versus outside of that. And you've worked in New York, where I did a sub-I at Cornell. And so I would go to clinic with Phil Steeg, and we'd see patients, and he'd be either the first out of five or the fifth out of five surgeons that they'd be seeing for the same tumor. And it didn't bother him at all. Oh, yep, it's completely normal. They make the round around the city, they see everybody. And so there was kind of that sales aspect to it, where you see
Oh
if it's
yeah.
a good fit and you tell them it should be here. And so you've worked in that environment, and now you're out there in their own backyard, and you're selling to them, you're convincing them same level of care, same expertise, but you don't have to go deal with all that, and the surge pricing to get into the
And
city,
the parking.
and the parking, right? So what is it like having those conversations when you're essentially convincing someone who may have that mindset that, oh, I should go to the ivory tower in the big city, and you're telling them, no, actually we can do it just as well right here, and you don't have to deal with all that.
Yeah, John, I think that's a great question, and that's when I talk to patients, I really think talk to them in terms of two things. Number one is technology. So I've made it my mission to make sure that the technology that I'm offering is as good, if not better, than anything that they're going to get
Mm,
in the city. I have an intraoperative MRI, right? I have brand new endoscopes. I've got all of the fluorescence. I use glialin. I use
mm,
everything that we're using in our toolkit in neurosurgery. I have and we're using. So technology is one piece of it, right? And then the care team that you build, right? The subspecialty aftercare. So that's really important. But ultimately, I think neurosurgery, picking a neurosurgeon is actually a very personal experience. Like, do they
mm,
want someone who's qualified and can do a good job? 100%. But they also want someone who's taking them through this really, really difficult and scary period of their life. And I think that what perhaps not everyone appreciates when you are in an ivory tower and people sort of just like come to you is that, a big part of what helps you keep a patient or a patient stick is your personality, and it's the connection that you make with that patient and them feeling like, well, there were all these great surgeons, but like this is the one that cares about me, and this is the one that I know will pick up the phone when I call and I have a question, or when I'm worried after surgery. I'm super fortunate to have nursing team and administrative team that are just absolutely remarkable, and care a lot about my patients, and I think they make the patient experience just absolutely phenomenal. So that's been the big difference. I've always been who I've been, but I have this like incredible team now that really, it feels more intimate, and I think patients appreciate that, and that's why they choose us. A lot of my patients do get opinions with several people in the city, and then they still choose to come here, and there's a reason for that. So we're lucky to have that. And then I think that as wonderful as these places are in the city, and nothing negative to be said about that, but there is something that sort of gets lost in a really big hospital. It's you become a little bit more of a number, and a little bit more of less of someone that is recognized by the people walking down the hall. And Valley has this kind of unique in between, where it's like this big beautiful hospital, but it still has that kind of like small hospital feel from a personal standpoint, and I think patients really, really do appreciate that. And that's and then word of mouth, like in this area, it's all people trust their primary care doctors, they trust their neurologists, they trust their ENTs. So we're really, really big on referrals, and the reason that we get a lot of patients is we have a lot of really good outcomes. So someone refers a patient to you, you have a great outcome, they're going to refer every other patient to you. So we really build ourselves up based on our outcomes, and that's been what has sustained our reputation and our referral base.
Yeah, Rupa, that's so refreshing to hear in this age when everybody's trying to do social media and marketing and other types of gimmick. I would call it gimmicky
Yeah,
outreach programs. You're saying, yeah, the value is in the care you deliver, right?
back to the
Um,
basics.
exactly, exactly. And I would ask you, like, I don't want to get overly invasive, but to me, it's so interesting the kind of practice you have. So obviously with Gamma Knife, you're working with a physicist, you're working with a
Mhm.
radiation oncologist, right?
Yep.
Is it mostly that you have cases that you bring to the Gamma Knife Center and they help you with it? Or is it more that there's just this sort of pattern of cases that flow to Gamma Knife and you're the person who does the neurosurgical piece of it? I understand it's probably a little bit
Yeah.
of both, right?
Yeah, I think it's a little bit of both. I think it's very synergistic. I think we work very closely with our physicists and with our radiation oncologists and really with the Gamma Knife team in general. The marketing there is great, and again, that we benefit from the value, the reputation of Valley, and they benefit a lot from our reputation as an independent practice. So it goes both ways. I think we do. What's unique about our Gamma Knife, we probably do a lot more benign pathology than a lot of other centers that are much more heavily focused on malignancy and metastases. Yes, of course we do those, but because we do have this like referral base for benign cases, we're doing a lot of acoustics and trigeminals, and that's actually like the majority of cases that we're doing on the Gamma Knife. So those really tend to come more from the streams of referral that I get for my surgeries, right? Like I work with ENTs for my skull-based tumors, and those are acoustics are coming a lot from that, and then the trigeminals from all of our networks with our neurologists. So I'd
Yeah,
say
I
it's
like
more that way.
I really do like what you said at the beginning when we opened this up about how this is really a minimally invasive surgery because if you think about it, like at our M&Ms, and of course M&M is a sort of a private closed setting, but it regularly comes up that a lot of the surgeons are doing these cases, and then one of the older more seasoned neurosurgeons will pipe up and say, why wouldn't you Gamma Knife this, right? And then
Right.
comes out the discussion, well, what about scar and what about the person's going to live longer? But actually, the reality is, if a normal human like any of the three of us were offered the option between a surgery and a Gamma Knife, the bias is going to be internally towards like, yeah, I'd rather you try to Gamma Knife this first, right?
Yeah, 100%. Yeah, 100%. And I think, the way that I think about skull-based surgery is that like the older school mentality was like, oh, it's a skull-based tumor, like you get it out and like they look however they look and they have whatever deficits they have. I have like a very different mentality because Gamma Knife is so, so effective. In my mind, there is absolutely no justification to have a deficit after the surgeries that we do. Like when I do acoustics, it is virtually unacceptable for me to have a facial. And if I do, it's probably because I didn't select the patient properly. Things happen, of course, but accepting deficit is just not something that I do because you have to nowadays, if you stop at the last 5% of the tumor and either watch and then or Gamma Knife the residual, that patient is going to have a much, much, much better outcome and quality of life than someone who's 47 years old and living with a facial their whole life. Like it's no longer acceptable. And I think that that's really the mentality that has shifted that I try to incorporate as a surgeon is like, well, what is the alternative? Like, what does it mean to be having the added risk of like that last, whatever, 2 to 5% of the tumor? What does that mean oncologically? What are the implications in terms of function? What are the implications from time? Like all these types of things. So, I really value being a surgeon that does both because it helps me know the risks of both and know where to stop with one and where to go with the other. And similarly, there's cases where I'm like, I think that doing the Gamma Knife, like you're going to have a very high risk of necrosis, and I think that, it's very, you're more likely to have a worsening of your tinnitus and you're more likely to have these symptoms. And I think you'll actually do better with surgery. So, I counsel them both ways.
You are really speaking our language on this show. There's so many things swirling through my mind as you were just describing your philosophy there that, stuff we've talked about before. The win-loss matrix is an idea of Dr. Wang's, the farmer and the hunter. And I think you're falling squarely in this quadrant of that Dr. Wang and I both fall into philosophically, where having the ability to do more things from minimally to maximally invasive expands your repertoire of possible interventions. So then you can truly be a minimalist and you start with the least invasive thing because you can always do more. And my former chairman, Rich Byrne, always used to say, better to leave a little tumor on nerve than nerve on tumor,
Yes,
specifically with acoustics. So
absolutely.
you are, none of this was planned, folks, but you are right in the pocket with us philosophically, and that
Perfect.
warms my heart. But similarly, thinking about that, how Dr. Wang was talking about these things that you can advertise to draw the patients to you, these technologies, and what you have available specifically in your hands because you do it all yourself. You
Yep.
mentioned before the clinical trials.
Yep.
And so I wonder if that's something that patients come to your institution to seek out. A lot of hospitals where I've worked, that's a way that patients come in because you could put out the call if you want to enroll in the trial. You can
Right.
advertise the trial, and whether or not they fit in, it still gets them to your door. So what are some of the trials that you're using there? Are they
Yeah.
technology based? Are they medication based?
Yeah, because I came out here 2.5 years ago, and so part of what I wanted to do was to offer trials. Certainly there's a marketing angle, but for me, it's really that I want it's not justifiable for me to be, a glioma surgeon and not have trials available to patients. I just like my patients to have a good outcome. Like I need to get them on a trial if they have good functional status. So it's very important to me to be able to offer that. And in fact, if they can't get on my trial, I try to get them on a trial in the area. And so I always know what's available to them. And I generally kind of screen them myself for all available trials and get them where they need to be. So, my number one priority is patients having the best possible outcome. So, so I think that having clinical trial options is an important part of that. Certainly for malignant disease. So I have a glioma trial right now for IDH, for wild type glioblastoma, independent of methylation status, and it's a upfront trial. So as soon after they get resected, they go on a treatment 2 weeks before the radiation and chemotherapy, and it's like a coenzyme Q10. So I offer that. My goal is to always have like one or two glioma trials. We just had a virus trial that recently ended, but for recurrence. So we try to have like, a new trial and then a recurrence trial. And then, I do have a SRS. So we're part of the SRS trial, the neoadjuvant versus adjuvant radiosurgery for metastatic tumors. So that is really looking at, does it make sense to be treating these tumors before surgery with radiosurgery, or should we be treating them after? And the idea is if you treat them before, you're decreasing the risk of leptomeningeal disease and such things. And so, I like that idea. It's a very simple trial for me to run, because I'm running these trials. I'm not a neuro-oncologist. It's great for me to have a trial that is a little bit more technical, and it's like we're doing the care that they would get anyways. It's just a matter of timing. So that's
Hmm,
like logistically a lot, simpler for me to run. And so I try to pick my trials, for things that are like in my wheelhouse that I can manage, right? I'm not doing like super complex chemotherapy trials because I'm not an oncologist,
right.
but I have a strong oncology background. So there's things that I'm very comfortable with. So, I try to balance it. But yeah, and then we're part of the QOD tumor registry. So that's really important to me. And through that, I do a lot of work. We're doing, writing a lot of papers now. And I'm, very involved with that kind of nationally. And then the SRS registry. So we do similarly, we have a lot of work that we do with them. And our goal is always to expand. It's always a give or take between like how much to push them and how many resources they can give me at the hospital. Because again, I don't have residents and medical students doing a lot of this work for us. So it's,
Right.
you are a little bit more dependent on getting FTEs and getting positions filled. But I've been very fortunate to have Valley as a partner. They're an incredible institution. They care a lot. They have a very robust cancer center and clinical trials network. So it's been fun, kind of like using different resources, and it's been different challenges. In some ways, it's easier than when I was at a major academic center where like I was having to compete with the neuro-oncologists who wanted their trials and the radiation people that wanted their trials. Now it's like I'm kind of like the game in town for the neuro stuff.
Yeah.
So I get to dictate the flavor and the number and the types of trials that we have. And so I really enjoy that.
Well, along those lines, I mean, I know that you interact with lots of young folks, but you're not in a residency program. We have, this podcast is the most listened to in our field, and a lot of young folks are listening. So as we draw this to a close, I wanted to make sure you had an opportunity to speak to a lot of the young, especially women out there who are listening from all around the world, actually, but especially in America, some words of advice, encouragement that you can offer them as they embark on their very nascent but promising careers.
Yeah, thank you. Well, it's funny. I think that I love the position that I'm in, and I'd say the only thing that I miss about being in an academic setting is that mentoring medical students and residents is one of the things that I value the most. That has sort of continues to pay dividends. Like I still have residents that around the country that were medical students I mentored that are you know constantly give me updates on their status. And I think that's so important for women in particular, where because there just aren't a lot of role models. So, what I would say is I'm very involved with women in neurosurgery. We are really committed to mentoring young women who are interested in pursuing neurosurgery. We have a robust mentorship network through that. I would say it is critical to seek a mentor. The most helpful thing you can do is to see someone that has a life that looks like something you would want to have, a person that looks like you in whatever either literal or figurative way that you want. But that helps you set a goal, and it helps you find a roadmap to how you might get there. And I think that particularly if you're questioning it and saying, well, I don't know, can I do it? Can I also be a mom? I'm a mom of two. Can you also have a family? Can you be a normal person? If you're wondering, don't ever give up. Go out and find the resources, find the mentorship, because I think that is this field will suffer if we don't continue to reach out to the incredibly talented, women and minorities that are underrepresented right now in our field. So
Well,
always
amen to that.
forward.
Amen to that. Doesn't get better than that. Dr. Jutani, we want to thank you so much for your time. This was really a delightful conversation. It was a lot of fun getting to know you even briefly, hearing about your background and the work you're doing now. Again, we want to thank Electa for bringing us together for this conversation and sponsoring it to kick off this new series in the new year, 2025. But for now, Dr. Rupa Juthani, thank you so much for your time and coming on the Neurosurgery podcast.
Oh, incredible. Thank you, John. And thank you, Mike. This has been such a fun experience for me. And, look forward to hearing more from what you guys do.